attend is what Alexander et al. Has to say. Few other common problems during incisor transition. I am sure all of us would have come across this ugly duckling stage where the patient comes to us at around 8 or 9 years and the parent complains about having a generalized spacing in the anterior region. So in my experience also I have seen my general dentist asking me what can be done, doctor, should we go for a FA? So my suggestion would be, first you take a OPG. Take a OPG to confirm whether it is a transitional malocclusion which has occurred exclusively because the canine eruption, it is going to add on pressure on the lateral root of the lateral incisor and it is going to cause the flaring. So this, nothing needs to be done by us. As the canine erupts, it's going to self-correct. So we just have to wait and watch. But yes, there are conditions where there is a mesiodense. It is mandatory for us to take a OPG to confirm that whether there is any pathology, any kind of pathology which is lying, which is causing the flaring. That is some part of us, some important step which we have to take. The other thing is lingual eruption of your incisors. This also we'll have to take a local IOPA and check if the resorption is evident enough. Why this eruption has occurred? Is there any other soft tissue or hard tissue local factors which is causing the eruption to occur more palatally or lingually? So this is again, we'll have to consider taking OPG when patients report to us with such problems. So generally, we'll have to see why this diastema has occurred. Is it generally it's actually wrongly diagnosed as hypertrophic frenum, or it is sometimes it is diagnosed as some kind of malocclusion which has to be treated. So we'll have to take into consideration by taking an OPG and then deciding on what treatment needs to be done. So then moving on to missing lateral incisors. So missing lateral incisors, the incidence and prevalence of missing lateral incisor is about 2 to 4% population we find missing lateral incisor. Essentially, we'll have to see how, as an orthodontist, how we are going to preserve that space for probably giving a dental prosthesis in the future, or are we going to convert the canine to the lateral incisor? How are we going to handle? So maintaining the space for a future treatment is also very essential. The picture on the see, if we have planned a dental prosthesis and I have given say for space maintenance I have given an open coil spring. Thereafter I bring about certain movement in the root also to diverge the root a little bit so that it will be easier for the placement of the implant or future prosthesis. So these are all part of the orthodontist work. And thereafter, now one other problem is crowding. Now, as far as crowding is concerned, we'll have to take into consideration the patient's profile. Is very important whenever we are trying to expand for a particular patient. Say for this particular patient, we had used a removable Has type expander for bringing about dentoalveolar expansion. So, but one disadvantage of this was the buccal tipping of the molars which has occurred, which has also actually extruded the molars. I have circled it in that picture. So this is one disadvantage which could occur because of exclusive dentoalveolar expansion which has occurred. This one other patient of mine who actually reported to us with a complaint of not able to breathe properly, and he's having difficulty in sleeping during the night time. So he was actually put through a series of tests for obstructive sleep apnea which came positive for this patient. So we actually gave a rapid maxillary expansion for this patient, and we also gave a bonded expander. The reason being, the patient is actually having an increased lower facial height already. So if we are going to have the earlier type of expander where the molars tend to extrude, it is actually going to increase his lower facial height and it's going to spoil his profile. So we don't want that to happen. So in this case, we have actually given a bonded type expander where the extrusion was prevented by these acrylic caps which are provided on the top of the teeth. The other common problems which occur during canine and premolar transition is ankylosis, abnormal sequence of eruption, early loss of primary teeth, habits, asymmetric eruptions, and transposition impactions, hypodontia and hypodontia. As far as ankylosis is concerned, is actually a little vast topic, wherein whenever we subject the patient to an orthodontic treatment and the teeth doesn't move at all. So the first thing which should strike your mind is you'll have to take a local IOP to check if the lamina dura is visible or not, to confirm if the tooth is ankylosed. And also we'll have to take a proper history of the patient if the patient has undergone any trauma of any kind during his early ages. So we'll have to take this and then take this into consideration on how we are going to go about treating this ankylosis. In general, if it's an anterior tooth, definitely the patient doesn't want a step kind of defect which is seen in this anterior teeth. So the one technique which can be followed, can be used is your segmental osteotomy, which can be done to bring about movement more incisively. Next condition is your lateral tongue thrust. That is, general tongue thrust can be complex or simple tongue thrust. Now onto the picture to my right, you can see the patient is exhibiting a lateral tongue thrust. The ideal clinical scenario of this patient would be the patient is presenting with a deep bite and the patient is having a lateral tongue thrust. Why this could occur is because the patient is preventing the molar eruption on the lateral sides. That is, the buccal eruption of the teeth is affected by the intervention of the tongue. So the anterior anterior teeth tends to erupt and form the anterior guide. So this is the reason why the patient ends up having a deep bite with lateral open bite. And with this tongue thrust in the where the patient might have a retained infantile swallow or an anterior tongue thrust, the patient might be presenting with an anterior open bite. So what are the treatment modalities for this? Is training of correct swallow and posture of the tongue is very important. Appliance to guide and correct positioning of the tongue, and of course mechanotherapy. So what are the myofunctional exercises we generally employ to the patient is educate the patient about how to swallow normally and keep the tongue tip against the junction of hard and soft palate. Various muscle exercises of the tongue can help in training to adapt to a new swallowing pattern. The child is asked to place the tongue in the rugae area for 5 minutes and asked to swallow. These are myofunctional exercises which is essential to prevent forward tongue thrust. And tongue tip against the palate and hold it, maybe an orthodontic elastic or any other material which can be used. If the swallow is correct, the elastic will be retained in its position. And the 4S exercises, that is spot, salivate, squeeze and swallow. We also have pre-orthodontic trainers to retain the tongue in that position. Next, moving on to an say case of an anterior crossbite. When the patient is exhibiting an anterior crossbite in his in his primary dentition itself. This is one case report wherein they have showed how we can actually engage lingual buccal buttons and engage elastics to prevent